So today's session is actually on carcinoma penis. So it is so overwhelming to see such a an interesting group of postgraduates, from various parts of the country participating in such academic forum. We have about nearly 50 participants now. And welcome, Dr. Srinivasan Ganesan. Good morning, sir. And good to have you on board today. And so today we are going to discuss the carcinoma penis. It's one of the very important short cases. We don't usually get CA penis as a long case, either as a ward rounds which is operated or as a non-operated case. We can have it as a short case. If at all there is a case of CA penis in the ward, at the time of exam, that will be a 200% short case for you. So today, the next couple of us will discuss carcinoma penis, and we will start with Bhavya presenting about brief history, and then we will discuss what are all the clinical features, what are the predisposing factors, the pre-malignant conditions, how the grading is being done, how the staging is being done, how staging has changed over time, the TNM staging, which was there earlier, and how changes have happened over time, what is the current consensus arrived at, and then we will discuss the role of imaging, what sort of an imaging we may have to do, what is the role of CT, MRI, what is the role of PET-CT, current role of PET-CT, everything we'll discuss. The management. Most important will be the lymph node management. So that will be the center of attraction of today's session also. And that is the area where the most of the postgraduates will fumble what to do when. So all that will be discussed, evidence-based EAU and AU-based, evidence-based risk stratification, and accordingly the management also. All that we will discuss today. Okay, over to you, Bhavya.
Yes,
Shall we start?
Yes, sir.
Please go ahead.
So the 60-year-old male patient former by occupation, came to OPD with complaints of growth over the penis associated with foul smell since 8 weeks, sir.
Okay.
History of presenting illness. Patient noticed painless growth over tip of the penis 8 weeks back, which was insidious in onset, started as a small induration of approximately 1 centimeter in size, rapidly progressed to present size, involving the whole glans penis. Associated with foul smell, purulent discharge from 3 weeks. Associated with thin stream of urine, not associated with any other urinary complaints. Initially, the prepuce was fully retractable. At present, it is only partially retractable and thickened. No history of trauma, no history of fever, no history of inguinal swelling or any ulcerations, no history of previous surgeries in the past, no history of multiple sexual partners, no history of exposure to unsafe sex, no history of urinary retention, no history of loss of appetite, no history of loss of weight, no history of pedal edema, generalized weakness or puffiness in the face, no history of bony pain, jaundice, hemoptysis, cough, or breathing difficulty.
Okay. So go back to the previous slide. Previous. Yes. See, all this should be in very short sentences when you present like this in a PowerPoint. And patient will not tell you initially it was fully retractable, now it is partially retractable, it is thick, and all that will be the examination. Okay.
Yes.
Patient will now tell you that he is unable to retract the prepuce. That is all the patient will tell you. Okay. So what are all the important, interesting points here in the history that will point towards one particular differential diagnosis?
The rapidly growing size of the lesion, sir.
Yes.
And there is an associated discharge from the lesion.
Yes.
And it is involving the urinary meatus. Because of that, he is having a thin stream of urine, sir, probably.
Very good. Okay.
And
so these are the important things.
Yes.
Okay, fine. Based on this, what do you think the probable diagnosis will be?
Sir, based on the patient age and the symptoms, I like to give differential diagnosis. CA penis, sir, condyloma acumata, Bruschi-Lewinson tumor.
A patient with an ulceroproliferative or whatever painless growth at the tip of the penis, rapidly growing, foul smelling, purulent discharge, is CA penis unless proved otherwise.
Yes, sir.
So that is the bottom line diagnosis that you'll have to think of. Okay, that is the bottom line statement that you'll have to make. Any lesion in the penis is carcinoma penis unless proved otherwise. If this patient also gives a history of something, then you will probably think of, you said human papillomavirus, condyloma acuminata and all. No? What is the history that will point towards HPV infection?
Multiple sexual partners, sir.
Does the patient have that history?
No, sir.
Doesn't have. Anything else that you can think of in asking in the history which can point towards the malignancy of the penis?
Bleeds
Smoking
and
history, smoking you mentioned. Smoking you mentioned.
I'll come, sir, to the personal history. Is a non-smoker, sir.
Okay,
Heavy
he's
smoker, actually, sir.
He's a heavy smoker. Okay,
Yes,
fine.
sir.
Yes, anything else in the history that can point towards a differential diagnosis? Or you complete the history and then I thought you have completed. Go to the next slide. You complete the history and then we'll come back again. Okay.
Yes, sir.
Next slide, Venkatesh.
Past medical history, sir. Means past surgical history, nothing significant, sir. Personal history, patient is having a mixed diet, normal appetite, normal bowel and bladder habits, known heavy smoker, more than 45 packs per year, sir. Family history, married with 2 children, history of sexual exposure at the age of 26 with only 1 partner, sir.
Go back to the previous slide. Go back to, he is a heavy smoker. When will you say that the patient is a mild smoker, moderate smoker, or a heavy smoker?
So based on the pack years, sir, number of cigarettes into how many years he has smoked divided by 20 will give you pack years, sir. If it is coming more than 40, he is a heavy smoker, sir.
I asked you what is the question. So you'll have to answer the question properly, not precisely. When will you say he's a light smoker, moderate smoker, or a heavy smoker?
When he is above 40 heavy smoker, 20 to 40 moderate smoker, less than 20 light smoker, sir.
Less than 20 pack years, you call him a mild smoker. 20 to 40 pack years, you call it a moderate smoker. More than 40.
Yes,
So he is a 45 pack years, so automatically becomes a heavy smoker.
Heavy smoker, yes, sir.
And anything else in the medical history you have mentioned? What is the medical history?
Any comorbidities, sir? Regarding any comorbidities, he doesn't have any comorbidities, sir.
What comorbidity will produce CA penis here? Diabetes, hypertension will produce? What is the comorbidity that you're talking about here? Or for completion's sake, you have asked for? Anybody else? Any significant medical history?
Human papilloma. Diabetic can lead to phimosis, which can chronic irritation, which can lead to CAS and leads to invasive.
No. Diabetes will produce melanocytitis.
What, sir?
Okay, penile what? Penile what you're talking about the HPV treatment for sexually transmitted diseases and all that. One important thing that you'll have to remember is whether the patient had the treatment for tuberculosis in the past, because tuberculosis of the penis is one of the important differential diagnoses that you'll have to keep in mind whenever you see a case of CA penis. Because tuberculosis is a great mimicker of CA penis. It will also present like an ulceroproliferative lesion. It can also present with a foul-smelling discharge from the surface of the lesion, and that can also produce voiding difficulty. Okay, so all this you have to keep in mind when you go back to the first slide. You mentioned the patient has got a difficulty in passing urine.
Yes, sir.
How do you correlate that with CA penis?
If the growth is at the penis, sir, at the glans penis, if tumor involves corpora spongiosa, it can easily involve the urethra, sir. Okay. There is no cavernosal bodies of the glans penis.
Basically, what you should again understand is that a carcinoma penis is an ulceroproliferative lesion which grows centrifugally. It is not an ulceroinfiltrative growth. So usually that does not produce any voiding difficulty. If CA penis has to produce a voiding difficulty in the initial setting itself, most of these patients would have come to the doctor, with voiding difficulty in the early stage of the CA penis itself. Because the patient does not develop any voiding issues, there is a considerable delay in presentation to the urologist, and most of the times what you see is a gross ulceroproliferative lesion, almost distorting the glans penis, almost distorting the meatus, and almost making the preputial skin non-retractable. So that is the presentation with which they usually will come to you. And one more important thing that you'll have to also ask in the history is, you talked about family history, you talked about sexual exposure at 26 years. You mean the patient got married at, say, 26 years? Is that what you are
Yes, sir. He got married, sir.
Say like that, because if you say sexual exposure, that means it is probably something apart from his wife that you are, that may
only one partner, sir.
Only one, no, one partner is okay, but that one partner is that the wife or somebody else. Okay,
Yes,
so
sir.
that is something which you'll have to clarify also. So if you say sexual exposure, that means it is a contact other than it's that is the usual meaning. Though technically speaking, what you say is right, but still, okay, frame the sentence properly. And
Yes, sir.
most important thing that you'll also have to mention in the treatment history is whether the spouse had taken any treatment for tuberculosis. That can also make the husband get the okay tuberculosis of the penis. That is one. And second thing is if the lady has had HPV exposure, so that HPV, if the lady partner has had human papilloma virus, that history also you should be whether she had taken any treatment for any vaginal discharge, whether she had taken any treatment for CSLX, whether she has had treatment for tuberculosis, whether she has had multiple partners. All those are the other issues which you'll have to take into consideration also when you ask history from the patient per se. Okay. So with
Yes,
this
sir.
history, what do you think? Can you complete the list of differential diagnosis?
Sir, elderly patient with a heavy smoker, sir, with unsafe sexual practice, with also proliferative lesions, sir. Most probably, my diagnosis will be CA penis, sir.
What
With
is
that,
unsafe?
like,
What is unsafe sexual practice?
sir, with multiple sexual partners, not using protective barriers.
No. Does the patient have that history?
No, sir, that's
No
unsafe
history.
sexual. Yes, yes, sir, with
No
no history of
unsafe.
unsafe. Yes, sir.
Okay. You are making double negative. Okay, fine. No history of unsafe. Okay, fine.
Yes, sir.
Okay.
So, like to give differential as CA penis, sir.
Okay. Good. Only one.
Sir,
Now the examiner will ask you, is there any differential that you can think of? So you will always say,
erythroplasia of curate, sir.
what is that erythroplasia of curate? Okay then.
Pre-malignant lesion of the glands penis.
Okay.
Then condyloma acumata also we can.
In the order of frequency, one is CA penis, that is the most likely possibility.
Yes, sir.
The
Yes, sir.
second one, condyloma acuminata.
Condyloma acumata.
And then
Erythroplasia of curate, sir.
curate. It's a giant condyloma acuminata.
Yes, sir.
Then
Pseudokeratosis malicious lesion, sir.
how many such cases have you seen? The fourth will probably be tuberculosis of the penis.
Tuberculosis of penis.
And then you
Yes,
will
sir.
talk about the other rare of the rarest, rarer pre-malignant lesions, all the list of all, including
Yes,
cutaneous
sir.
horn, all that you will list out. If the examiner is asking you anything else, you will ask all.
Yes, sir.
Okay.
Yes, sir.
Yes, Dr. Srinivasan Ganeshan mentioned. No? See, we have to always, it's a very important thing, point that Dr. Srinivasan has raised. Use very, very common language. Don't use with no history of unsafe practice. Not required at all to mention like that. Don't put two double negatives in that. Not
Yes, sir.
required. Use always simple language. Profuse is retractable, profuse not retractable. That's all. Like that. No, always use simpler.
Yes, sir.
So your probable differential diagnosis is carcinoma penis.
Yes,
Okay.
sir.
So with this in mind, you would like to examine the patient, isn't it? Okay. Can we go ahead with the examination?
The general physical examination, sir. Temperature afebrile, pulse rate 74 beats per minute. Patient is conscious oriented, well built and nourished. Clubbing is present. Sir, general examination, local inspection, sir. Ulceroproliferative growth of 5 into 6 centimeter over the penis, extending from the glans penis, involving the prepuce ventrally in the distal 2 centimeters of penis. No proper margin is made out. Surrounding skin looks edematous. Discharge is seen. Pinpoint meatus can be seen. No visible swelling or redness noted on the shaft. No swelling noted on the inguinal region. Palpation, ulceroproliferative growth of size 5 into 6 centimeter on the glans penis involving the prepuce ventrally, hard in consistency, painless, but bleeds on touch with irregular margins, everted edges, floor is indurated, covered with slough. Foreskin could not be retracted. The pinpoint meatus was visible. Growth could be palpated below the foreskin up to the coronal sulcus. Induration can be felt at the distal 1/3 of the ventral penis in a stretched position, seemingly involving corpora spongiosa. Proximal margin of indurated was approximately 3 centimeters from the base of the penis. No palpable lymph nodes noted in the inguinal region. Scrotum bilateral test is normal. DRE grade 1 prostatomegaly, firm in consistency, rectal mucosa mobile over the prostate, anal tone normal. Other systemic examination, per abdomen normal, soft normal, CVS S1, S2 heard, no murmurs, RS bilateral air entry present, no added sounds, CNS no focal neurological deficit, spine and cranium normal, sir.
Okay. The examination complete?
Yes, sir.
Okay. So what do you think is the clinical stage of this particular lesion if it were a malignancy? If it were a
Sir,
squamous cell carcinoma?
yes, it should be T2 plus, sir.
Why T2 plus?
Sir, it is in the glands involving until corona, and
Okay.
lesion is fixed with the indurated margins.
Okay.
Patient also gives complaints of thin flow, sir. So probably urethra might be
Yes.
involved. If urethra is
That is
involved, it
what?
should be T2 plus, sir.
No, that is the first thing you should mention. If you say it is T2 plus, I get the impression that you're only talking about the widening difficulty that this patient has got. Probably the spongiosal involvement. When there is a spongiosal involvement, it becomes automatically a T2 lesion. Earlier it was a T3 lesion. Now they have brought it down to T2 because the spongiosal invasion occurs much more frequent. So T2 it is at least a T2. So that much of information you have.
Yes, sir.
And clinically it is N0. Okay, clinically it is
No
N0.
notes palpable.
When you want to examine for the linguinal lymph nodes, how do you look for, how do you palpate the linguinal lymph nodes?
Sir, there is a superficial deep node, sir. Vertical and horizontal group we have to
No,
palpate,
how
sir.
do you examine the patient? You put the patient lithotomy and examine, put the patient supine, prone, or left lateral, right lateral. How do you do that?
Supine position, sir. With the
And
legs flexed, with relaxed abdomen, legs flexed
leg is flexed. Where do you flex the leg?
at the knee joint, sir.
The joint and
Hip slightly external rotated, sir.
hip is
Slightly
external or internal rotated?
internal rotated, sir. Slightly
Hip is,
internal rotated.
so when you examine the patient for inguinal lymph nodes, the hip is internally rotated with a slight flexion of the knee joint. Okay, so that will make the tensor fascia lata a little lax. Okay, so that is the whole objective. Okay, and then where will you palpate the inguinal lymph nodes?
Sir, along the inguinal ligament, sir.
Along the inguinal ligament or just below the inguinal ligament? Inguinal ligament runs between the pubic tubercle and the
Yes, sir. Any node palpable 2 centimeters below the inguinal region, sir.
Yes, you'll have to run your finger below the line of the inguinal ligament and see if there is any mass which is palpable. That will tell you whether there is a node, inguinal node or not. That is the way
Yes,
you look for. And then you look for if at all node is palpable, you count the nodes that are palpable and then also see if it is a mobile node or a fixed node. Okay, so that is the way you clinically examine the inguinal lymph nodes. So there are no lymph nodes here. So it is basically a T2 plus lesion, CT2, CN0, MX.
MX, sir.
Okay, that is the way if it is a malignancy. It may be malignant or it may be anything else also because you have given a list of differential diagnosis, including condyloma acuminata or giant condyloma acuminata, tuberculosis. All this you have mentioned.
Yes.
Okay.
Yes, sir.
So what do you want to do now?
Sir, I want to do basic investigations before I do edge-wedge biopsy of the tumor, sir.
What basic investigation you want to do?
Sir, CBC, RFT, electrolytes, LFT, urine routine and urine culture, sir.
Okay. Do you think all this will influence your decision making of whether a biopsy is required or not?
No, sir. Only coagulation profile is required to do before the edge-wedge biopsy, sir.
Is it really required to do a coagulation profile? See, you can ask for a coagulation profile. You can ask for a complete blood count. You can ask for RFT, LFT. You can ask for all these things. But that you will not wait for all the reports to come to decide on whether a biopsy is required or not. You will ask also for a PT, PTT, INR also. You can ask for bleeding time, clotting time. You can ask for platelet count. You can ask for all the coagulation assessment you can always do. but you don't wait for all the reports to come before you initiate a biopsy. The moment you see a patient with such a lesion, you will always take him to the next room and do an edge-wedge biopsy, provided the patient is willing for it. That is the only thing
Yes,
which
sir.
you'll have to ascertain. You have to
Yes,
get a consent. You'll have to make sure there is somebody available by your side. Okay. And you have to do a biopsy and also simultaneously ask for all these investigations. Okay.
yes, sir.
And what all have you asked for? You have asked for hemoglobin, total count, platelet, all within normal limits.
All
Creatinine
within
is
normal.
normal, electrolytes are normal. Is there anything else that you would like to ask for?
Serum calcium, sir.
Calcium, yes. Serum calcium you'll have to ask for. Whenever there is a suspicion of a malignancy of the penis, serum calcium you will ask for. Why do you need a serum calcium?
Metastatic disease can produce PTH-like peptides, which release serum calcium, hypercalcemia, sir, or osteoclastic action of the tumor itself on the bone can cause resorptive hypercalcemia.
Yes, number one, yes, if there is a bony metastasis that can cause osteoclastic deposits and that can cause demineralization of the bone, calcium may get into the circulation, produce hyperkalemia. The other one you said is
Uh, Paraneoplastic syndrome kind of.
you have to mention that word. No, it's a PTH related polypeptide that is produced by that will cause hypercalcemia, irrespective. That
Yes,
has
sir.
got nothing to do with the metastasis. Even if there is no metastasis, there can still be hypercalcemia because of a paraneoplastic manifestation
Yes, sir.
with the PTH related polypeptide being produced by this. Where else do you get PTH related polypeptide as a paraneoplastic manifestation?
RCC, sir.
In narcissism. So, in both the conditions, you will ask for serum calcium. Okay, the two urological malignancies where you will ask for serum calcium as a first line investigation to look for any paraneoplastic manifestation are RCC and CAPNS. You will also ask for calcium. You will also look for hypercalcemia in patients with
CA prostate also.
CA prostate also.
Bony lesion, osteoclastic activity will be there.
Fine. Okay, go ahead.
Then edge-wedge biopsy was done for the patient, sir.
Why do you want to do
Which,
an edge-wedge biopsy here?
sir, usually this is a tumor of centrifugal, sir. So centrally there will be necrotic tissue will be there. We cannot see the depth of invasion at center. So we have to take part of a normal tissue with the tumor tissue to look for the depth of invasion, to look for proliferative cells, to avoid necrosis, sir.
There are specific reasons why you do an edge-wedge biopsy. Number one, when you do at the edge, what happens is the rapidly proliferating cells are located more at the periphery. The central area will have more necrosis. So if you take a biopsy from the center, there will be necrosis and you will not be able to see anything at all in the biopsy, number one. If you take it from the periphery, the rapidly proliferating cells will be more there, so yield will be more. And number three, you will always have some sort of a comparison with the normal tissue also. So you'll have malignancy on one side and comparison, malignant cells on one side, and on the other side, you'll have normal cells to compare with. So that's the reason why you'll have to go for an edge-wedge biopsy. These are three reasons why you go for an edge-wedge biopsy. Number one, you can compare with the normal cells. Number two, you'll have rapidly proliferating cells in the periphery. Number three, central area will have more of necrosis. Okay, fine. So what does the edge-wedge biopsy show?
It showed hyperplastic stratified squamous epithelium with ulceration and necrosis. Also seen infiltrating malignant epithelial tumor with cells that are oval to polygonal, having vesicle nuclei, abundant eosinophilic cytoplasm, plenty of keratin pearls, dense lymphocytic infiltration. The impression as squamous cell carcinoma, moderately differentiated, high grade, sir.
Are you comfortable with the way this reporting is done?
So they have not mentioned about WHO IECP grade, sir. They just told high grade.
What do you mean by moderately differentiated? What do you mean by high grade?
Sir, when the number of undifferentiated or poorly differentiated cells are high, Broader has graded the microscopy based on poorly differentiated or not well differentiated tumor cells, sir. When they're above 50 to 75, it can be called as moderately differentiated.
No,
above 75,
no, I'm not asking that. What I'm asking is, both are same or both are different? Mild, moderate, and poorly differentiated.
No, sir, they are different, sir.
No. They are same actually. Both actually talk about the grading here. The degree of differentiation denotes the grade. Mild, moderate, and severe is one type of grading. Low grade, intermediate grade, high grade is another type of grading. That's all. So whether you call it a broader, whether you call it WHO, or whether you call it a MIT grading or classification, that doesn't matter to you. What is the one that you normally follow these days?
WHO grading.
To follow WHO. So you don't have to talk about broader at all. When you talk about WHO, how do you grade this?
Grade 1, grade 2, grade 3, sir. High grade is there, it comes under grade 3, sir.
Grade 3. So you call it a G1, G2, and G3 these days, isn't it?
Yes, sir.
So there is no need for you to, if it is G2, it is moderately differentiated automatically. So there is no need to say it is moderately differentiated, no need to say it is high grade again. Both are contradictory. If it is a G2, it will be moderately differentiated. High grade will be poorly differentiated. So when you say moderately differentiated on one side, and when you say high grade on the other side, it becomes a little confusing. Why is it important? It's because you are dealing with the CN0 nodes here.
Yes, sir.
You have a malignancy squamous cell carcinoma. Squamous cell carcinoma, according to one part of the report, it is a G2 lesion. The other part of the report, it is a G3 lesion. And if this happens to be a T1 lesion, you are not talking about the vascular invasion also here, isn't it? Are you talking about the vascular invasion here?
Lymphocytic
No, have you mentioned that here?
No, sir. They have not.
You have not mentioned, isn't it? You have not mentioned. When you have not mentioned that, so how do I know whether what you're dealing with is a T1 or a T2 lesion or T1A or T1B? Isn't it?
Yes, sir.
So what is T1A and what is T1B?
Sir, T1A is divided into two, sir. Anything above the connective tissue above is T1A with low grade. G1, G2 is low grade, sir. Without perineural involvement, PNA and lymphovascular involvement is not there. It is considered T1A. T1B is above lamina propria with high grade lesion with perineural and perivascular lymphovascular invasion is present, sir.
So we have be very clear in your answering. Okay. T1 is invasion of the subepithelial connective tissue and lamina propria. Okay.
Yes, sir.
Very simple. Okay. So T1A and T1B both actually invade the subepithelial connective tissue. Okay.
Yes, sir.
T1A is no lymphovascular invasion or perineural invasion.
Invasion is not there.
And it will be either a G1 or a G2 lesion.
G2.
T1A, G1, T1A, G2, both will be T1A lesions only. Okay.
Yes,
if there is a lymphovascular invasion or perineural invasion, or if it is a G3 lesion, even if it is a T1, it becomes a T1B only.
Yes, sir.
Now you tell me in this report. You are not talking anything about
perineural invasion. They are not mentioned about lymphovascular invasion or perineural invasion, sir.
So that
only high grade they told. So it comes under T1B, sir.
It comes under T1B. When it is a G3 lesion, it automatically becomes either T1B or T2 lesion. That we do not know here.
Yes, sir.
Okay, because you have taken only a small portion of the way. So it is at least a T1B. So that much of information you have. So it is a T1B and it is a G3 lesion. So if you don't want to classify it as T1A and T1B, it becomes a T1 G3 lesion.
Yes, sir.
Now you will have to do a risk stratification based on this, isn't it?
Yes, sir.
So how do you do a risk?
Sir, it is divided into four, sir. Very low, low, intermediate, high risk, sir. Very low lesions who has T1, TA and TAS, varicose carcinoma and carcinoma in situ falls under the very low risk with no metastatic risk, sir. Okay. Then low risk are T1A who have G1, no lymphovascular invasion and no perineural invasion. They have lymphatic metastasis around 10%, sir. Okay. Then the intermediate risk is T1B, which are high grade with lymphovascular invasion, perineural invasion is present. They have risk around 30%, sir, 30 to 40%. Then high risk are T1B plus, including T2, T3, T4, which have metastasis around 30 to 70%, sir.
Very good. So this patient, what is the probability that they will have a very falling under a low risk or intermediate or high risk category?
Intermediate risk they fall. Minimum is intermediate risk, sir.
It is more than T1B.
High risk, sir.
So this patient falls. So this patient falls under a high risk category. It's very important for you to do a risk stratification here because your entire treatment will be actually based on that. Okay.
Yes, sir.
So you have now got a rough idea that it is going to be T1B at least.
Yes, sir.
So that much of an information you have. Now you need to know after final treatment of the definitive lesion, you will know whether it is only T1B or T2 or T3 or beyond that.
Yes, sir.
Okay, that information you'll
Yes.
get after either a partial amputation or a total amputation or whatever you do. Okay.
Yes, sir.
So this much of an approach you should all be very, very clear about. Okay. So so I will summarize it till here now. A patient coming to you with an ulceroproliferative lesion. Okay, when a patient comes to you with an ulceroproliferative lesion, you think of the possibility of a squamous cell carcinoma of penis, which is the most common lesion that you get if it's an ulceroproliferative one. Okay, so that much you should know. First, you make a provisional diagnosis. Then you do all the examination relevant to that. Then you do an edge wedge biopsy. Also, simultaneously ask for blood biochemistry and confirm the diagnosis. So when the diagnosis is squamous cell carcinoma, then you need to know whether it is a T1 or a T1 lesion, T1A or T1B, G1, G2 or G0. That much information you will get from your edge wedge biopsy. So in your edge wedge biopsy, you should number one get the histological diagnosis. You should ask for perineural invasion or lymphovascular invasion, perineural invasion. That much of information at the end, whether it is a low grade, intermediate, high grade, or low grade or intermediate. So that information you should be able to. Okay, so that information.
Yes,
So maybe they should have probably also given you the lymphovascular invasion.
yes,
Sometimes they will say that we could not identify in a small specimen that you have sent. They may say that lymphovascular invasion could not be ascertained. Because either way you see, all that you need is only a low grade or high grade. And then tissue diagnosis with squamous cell carcinoma is the most important thing that you'll do, because your final confirmation will again be after your amputation of the penis.
Yes,
Okay.
sir.
So what next
Yes,
you
sir.
want to do?
I want to do metastatic workup, sir. Chest X-ray and ultrasound abdomen to rule out pulmonary and liver mets, sir.
You said you are not able to palpate the inguinal lymph nodes.
Sir,
What does
for
that mean
liver,
to you?
yeah.
Sorry?
There is no metastatic, sir. If there is no lymph node metastasis, there is less likely that it has spread.
No, you cannot make such a blanket statement. When I'm asking you a specific question, that means I've got something else in mind. That is why I'm asking you. So you'll have to read the examiner's mind and answer accordingly. That is the trick that you'll have to follow in the exam. You mentioned that the nodes are not palpable.
Yes, sir.
Then after that, again, I'm asking you, what do you mean if the nodes are not palpable? That means there is some catch in that. Okay. If the node is not palpable, that either means that there is no node enlarged and palpable, or it can also mean that there may be still some nodes which are enlarged, but you are not able to palpate them.
Yes, sir.
Do you understand?
I understood, sir.
Either the nodes are not there at all, or the nodes are there, but you are not palpating. Then the first situation, very straightforward one. There are no nodes at all. When will there be a node which you are not able to palpate?
When patient is obese, sir,
Patient is very
when
obese.
they have prior inguinal surgery or any RT was
Very
given
good.
to inguinal lesion, sir.
Yes, sir. So if the patient has had a prior surgery, that is what the relevance of surgical history will be. If he has had a treatment for hydrocele, if he has had a treatment for varicocele, or if there has been a history of hernia repair in the past, there is a possibility that the lymphatic channels may be violated, in which case there may be still some other nodes which are enlarged, but the inguinal nodes are not palpable. Because in CA penis, there is a definite set path that the tumor cells will follow. You have a sentinel lymph node, you have step 1, step 2, level 1, level 2, level 3 group of lymph nodes here. Extremely unlikely that the malignant cells will bypass the sentinel lymph node and go up the order. It is possible, but still, you'll always think of the sentinel node to be enlarged first, in which case you'll be able to palpate. Okay?
Yes, sir.
That is the impact. So if the patient is an obese individual, supposing your patient has got a thick pad of fat there, and there is about 8 millimeter, 1 centimeter node which is enlarged, but you are not able to palpate that. So your investigation, further evaluation will again change accordingly.
Yes, sir.
Isn't it?
CT we need to do that.
That is the time when the examiner will ask you what are the indications for doing an axial imaging in a patient with CA penis. Now the diagnosis is confirmed here. The patient has got a squamous cell carcinoma of penis. G3 lesion.
Yes, sir.
Okay, a T1 G3 lesion the patient has got.
Yes, sir.
So now, when will you do a CT abdomen? When will you not do a CT abdomen? Okay.
Sir, if it's a thin individual with no clinically palpable nodes, no need to do CT, sir. If
Repeat
it's
again.
sir, if it's a thin individual with no palpable lymph nodes, no need to do for CT, sir. Since it is a T1B plus lesion, we need to do bilateral superficial inguinal lymph node dissection, sent for frozen, sir.
No. You have still not completed the indications for doing a CT.
Sir, obese individual with prior surgery, prior RT are the indications for CT scan, sir.
Okay. So obese individual in whom you are not able to palpate, or the patient has had a previous inguinal surgery is done, or patients have had a radiation. Why radiation? Or radiation of what?
Sir, for prostate lesion, he might have underwent radiation. For anorectal malignancies, he might have undergone radiation. Or generalized lymphadenal
If that
medical.
is the case, do you think that the CF penis will violate the lymphatics and go elsewhere? Is that what you mean?
They might have a fibrosis of that area where the lymph nodes cannot be palpable, sir.
Yes, that is the reason why. Because the fascia later may be getting fibrosed in that, so you'll not be able to palpate the lymph nodes at all. Okay, the fascia later or the deeper membranous layer of scarpa both may get fibrosed, as a result of which you'll not be able to palpate the lymph nodes. Okay.
Yes, sir.
Okay, so that will be an indication again. So obese individuals, previous history of inguinal surgeries, previous history of irradiation to the groin area, these three instances you will do a CT. Any other condition where you will do a CT abdomen?
The patient is having lower limb edema, sir.
If the patient is having, what does that mean to you? Lower limb edema due to what?
Sir, maybe patient is having pelvic lymphadenopathy compressing the vein.
If the patient has got a pedal edema, if the patient has got a pedal edema, lower limb edema, then you will think of the possibility of there being a pelvic lymph node which can obstruct the lymphatics and cause edema here in the lower limb. Okay, fine, very good. Then anything else?
It has gone to paracaval, para-aortic lymph nodes.
How do you know? How do you know that it has gone to paracaval, para-aortic? You do not know. You have not done. I'm asking what are the indications for CT abdomen? Only if you do a CT abdomen, you will know whether it has gone beyond. Clinically, if there is a lower limb edema, then you will suspect a pelvic lymph
Yes,
node,
sir.
in which case you will do a grade, but not paracaval nodes. Patients with palpable inguinal lymph nodes. If the patient has got palpable inguinal lymph node, you need to see whether the patient also has got pelvic lymph nodes or not.
Yes, sir.
Isn't it?
Yes, sir. Yes, sir.
What is the probability that a patient with a palpable inguinal lymph node also have an associated pelvic lymph node?
Around 30%, sir. If
30 to 50%, 30 to 50%, up to 50% from low grade to high grade. A high grade lesion, 30 palpable lymph node, up to 50% of them can have a pelvic lymph node. If supposing you are planning for if the palpable lymph node, you are planning for an ilioinguinal ipsilateral, in which case you open the pelvis and see that there is a big node, about 6 centimeter node, inoperable. The whole management will change again, isn't it? So it is always important for you to ascertain that the pelvic nodes are enlarged or not enlarged, especially if there is a palpable inguinal lymph node. You
Yeah.
understand?
Understood, sir.
You will do a CT abdomen. Is there any other indication for doing a CT abdomen? Patients with inguinal lymph nodes in whom you think it is either a large inguinal lymph node, if you think it is a fixed inguinal lymph node, or in patients in whom you are contemplating a biopsy of the pelvic lymph node to start a neoadjuvant therapy. You understand?
Yes, sir.
If supposing there is a large 5 centimeter inguinal lymph node,
To
okay,
start new.
if
Yes, sir.
you are going to start the patient on neoadjuvant chemo, isn't it?
Yes, sir.
In patient who has got a fixed inguinal lymph node, maybe 3 centimeter, but very hard and fixed. If you want to start a neoadjuvant chemotherapy, you may have to do a CT abdomen to see if there is anything else in the pelvis or not. Okay.
Yes, sir.
So what are all the list out the indications for doing a CT abdomen and CA penis? Number one, obese individuals in whom you
Prior
are not able
radiotherapy.
to palpate, in whom you are not able to palpate the inguinal lymph nodes.
Yes, sir.
Patients with prior inguinal surgeries, it may be inguinal hernia surgery, it may be varicocele surgery, hydrocele surgery, whatever it is, whatever it may be.
Yes, sir.
If the patient has had a previous inguinal surgery, the lymphatics may violate the normal set path. Patients who have had irradiation, in whom again there will be a technical challenge in palpating the lymph nodes because of fibrosis of the membranous layer or the fascial layer. Patients with palpable inguinal lymph nodes, where you may have to see and look for the presence or absence of pelvic lymph nodes, which can happen in as high as 30 to 50% of individuals. And patients with inguinal metastasis, in whom, if it is a large mass, fixed mass, immobile mass, where you may have to start on neoadjuvant chemotherapy. Okay.
Yes, sir. Yes, sir.
So these are all the indications for asking for a CT abdomen. The exam, if they ask you, when all will you do CT abdomen? Any one of these scenarios, you will do a CT abdomen. Otherwise, CT abdomen per se is not routinely indicated. Not routinely required. But you will do an ultrasound of the abdomen, definitely. Ultrasound of the abdomen will pick up a node, comfortably it will pick up a node which is as high as 2 centimeters, at least. CT will pick up as low as small as 1 centimeter. Oral and IV contrast, if you give, it can pick up a small node which is as small as 0.5 centimeters.
Yes, sir.
So if you do an ultrasound, at least a 2 centimeter lymph node mass can easily be picked up. In which case, there is no real need for you to go for a CT abdomen in all patients with CA penis. Okay.
Yes, sir.
So what next you want to do now?
Sir, ultrasound abdomen and chest X-ray, sir.
So before doing a partial amputation or a total amputation of the penis, you will decide on whether a CT abdomen is required or not. Okay. Fine.
Yes, sir.
Okay. So what do you want to do now?
Chest X-ray and ultrasound abdomen, sir.
Chest X-ray and ultrasound abdomen.
Um,
In the meantime, this patient had some staph epidermidis grown in urine. No?
Yes, sir.
What does that mean to you?
Sir, probably it's a skin commensal, sir. Due to ulcerative lesion, got contaminated, sir.
Okay. There are some secondary infection, skin lesions, skin infection, secondary contamination. Okay. So you will not attach much importance to that. In which case, why do you have to do urine culture at all then?
Sir, more than urine culture, the purulent culture is also required, sir. To if at all, if it is low stage, a low risk individual, if nodes are palpable, we need to start antibiotic for 4 weeks. That is the
Very
only
good.
scenario we need to.
Excellent. Very good. You do these cultures because if you have a palpable inguinal lymph node, the inguinal lymph node may be a metastatic one or it may be an infective node. In which case, before you plan for a definitive therapy for inguinal lymph nodes, you'll give the patient a sufficient course of antibiotics before you decide on whether the node had to be knocked off or not. Okay?
Yes, sir.
So for that, all this will be important. All this will be useful. If supposing this patient needs an inguinal lymphadenectomy, you'll give the patient, because there is some skin infection here, contamination here, you'll treat them for a couple of weeks with appropriate antibiotics, and then you'll go ahead and do the definitive treatment for the inguinal lymph node. So for that reason, this culture will be useful. That is the way you'll have to. Okay, here X-ray test is normal, ultrasound abdomen is also normal. Okay, fine.
Yes, sir.
So what next you want to do?
Sir, partial penectomy plus bilateral superficial inguinal node dissection, sir.
You will do all at the same sitting?
Yes, sir. Because it's a high risk patient, we need to just sample the inguinal nodes to check for frozen section or to check for HP. If that comes positive, later on we can plan for the whichever side came positive, we can plan for ilioinguinal node dissection, sir.
So what will you do now?
Partial penectomy with the bilateral superficial inguinal node dissection, sir.
Why not a total penectomy? Why you want to do a partial penectomy?
3 centimeters of stump, 3 centimeter, the lesion is almost 3 centimeters from the base of the penis, sir.
Okay.
To organ preserve, sir.
No. See, what is the indication for partial penectomy is that if you are able to give the patient a 0.5 centimeter clearance with a stump which is adequate enough, with a stump which is adequate enough for him to void in erect posture, the partial penectomy is indicated. You understand?
Yes, sir.
You may have to tell in the exam if they ask you like this is, if in case you are able to give a 0.5 centimeter clearance all around, number one, and number two, still you'll be able to achieve a stump which can make the patient or enable the patient to void in erect posture, then partial penectomy is indicated. Is that clear?
Yes, sir.
So in this particular individual, we have not still seen the shaft properly. The picture that you had shown was an end-on view on the lesion only. We have not seen the shaft. Assume that the shaft is normal here. In which case, if you are able to get an adequate stump for him to void in erect posture, the partial penectomy is indicated. That very clear?
Yes, sir.
If you have a doubt, then it is always better to go for
Total
penectomy and perineal urethrostomy. That is
yes,
the answer that you'll have to give in the exam. Okay.
Yes,
now, the next question is, will you just do a partial penectomy now and then do an inguinal dissection on a later date, or would you like to combine both at the same sitting?
Already HOH biopsy has given it as a high grade patient, sir, and
Okay.
there is no clinically no nodes. So we need to do sampling of the superficial inguinal nodes to complete the. Sir.
No.
If
Why
they
I'm
come
asking this
positive,
is because if you go ahead with a superficial inguinal dissection, you should be prepared to go with the deep inguinal dissection also, and you should be prepared to go with the pelvic lymph node dissection also. You understand what I say?
yes, sir.
If supposing you are doing a superficial sampling and that comes as positive, what will you do?
Ipsilateral inguinal block dissection we need to do.
No, inguinal already you have done inguinal. Superficial inguinal you have done. You have to go for a deep inguinal.
Yes, sir.
You have to go for a deep inguinal, and then ipsilateral you have to go for iliac dissection also. Isn't it?
Yes,
It is always safer for you to tell in the exam that this patient had staph epidermidis grown. That area looks a little infected. Let me not unnecessarily contaminate the groin also with that infection. Might as well get rid of the malignant portion first, and then probably a couple of weeks I'll give him appropriate antibiotics for that skin infection that he has got, and then I will electively plan for a bilateral superficial inguinal dissection on a later date.
Yes.
In the meantime, I'll also cross-check whether it is only a T1B lesion or whether it's a T2 lesion or whether it's a T3 lesion. Plan accordingly.
Yes, sir.
That in the exam, you can always say, play it very safe in the exam. Always play it very safe in the exam. Never be heroic in your answers. You can always wait for this patient has waited for so long. He can wait for some more time, isn't it? He can wait for a couple of weeks more. You don't. The earlier concept was 4 to 6 weeks of antibiotics and all. Now that is not being followed by anybody. All that you need to do is to make sure that you cover that particular infection with adequate antibiotics, and then you can go for a. Will you go for a modified or will you go for a radical dissection?
Modified Catalona.
Modified Catalona.
Modified Catalona.
No, Catalona is modified.
Modified.
Or you want to modify that Catalona also?
No, sir. Modified Catalona.
So you will not go for a Dessler, you will go for a Catalona dissection. So that is what you are trying to say, isn't it?
Yes, sir.
Okay. Now, Dr. Srinivasan has asked one question. What is it? I saw one pop up there.
Role of PET CT, sir.
Dr. Srinivasan has asked, is it not clinical T2? How do you interpret? How do you answer that?
Sir, urethra was involved, sir. So clinically T2 plus, sir.
Here, if the patient has got voiding difficulty, so it has to be at least a T2 lesion.
Yes, sir.
Okay, so that is the way you'll have to interpret. Okay,
yes,
if you look at the edge wedge biopsy, it will be T1B plus.
B plus.
If you look at it clinically, it is at least a T2.
T2 plus.
Okay, it's very relevant. And what is the role of a PET CT? Dr. Srinivasan has asked. We talked so much about the role of CT when the CT is required. Now, Dr. Srinivasan has asked. Dr. P.V. Srinivasan is a senior consultant urologist from Kadalur GH. And he has asked very relevant, pertinent question here. What is the role of a PET CT? Bhavya, can you explain the role of a PET CT here?
So, role of PET CT comes only when there is a inguinal node positive, sir. Only in those individuals we can do PET CT, sir. It can give us about the pelvic node positivity and also the contralateral node positivity.
No, you cannot say only if there is a palpable inguinal lymph node. That you cannot say. If supposing this patient has had the same logic applies, no, where all you can apply
Yes, sir.
a CT. If suppose this
Yes,
patient has had radical inguinal surgery, okay, hernia plasty has
yes, sir.
had
Yes, sir.
no palpable lymph node, but still you can do. Now the issue is when you want to do a CT, will you do a regular CT or it may be a plain CT or a contrast enhanced CT with oral and IV contrast on one side, or the PET CT on the other side? Which one will you prefer?
Oral
You have
IV
decided to
contrast
do a
CT, sir.
CT.
Yes, sir.
Which one will you
Oral,
prefer?
oral IV contrast CCT, sir.
Sorry?
Oral IV contrast CCT, sir.
No, Naima. You are doing a CT, no?
Yes, sir.
For select individuals listed at 1, 2, 3, 4, 5.
Yes, sir. Yes, sir.
Instead of a CT, can you go for a PET CT straight away?
Guidelines are telling only to do CCT, sir. Role of PET CT comes when there is only inguinal node positive to check for pelvic nodes, sir.
No, inguinal node positive.
Or a
You will
bigger
do.
node when plan to start neoadjuvant chemotherapy, we can do PET CT, sir.
No, you instead of doing a CT, a whole abdomen, can you straight away go for a PET CT if it is available in your setup? What is the answer that you will give? See, you are working in a
Sir,
center.
partial penis can have infection, sir. So nodes can take up higher SUV if it is infected also, sir. It will give false positivity high, sir. So CECT is only better investigation, sir.
What answer you should give is that, sir, in places where a CT is done, you can also do a PET CT, no harm at all. Okay, Bhavya,
Yes, sir. Yes, sir. Yes, sir.
you
Yes, sir.
can always do a PET CT also. The
Yes, sir.
problem here with PET CT is that it does not give you any additional information beyond what a regular CT will give. Okay.
Yes, sir.
So PET CT has got no specific role to play in the initial evaluation. Okay.
Understood, sir. Yes, sir.
If supposing in PETs in regular CT, if the patient has got pelvic lymph nodes palpable, pelvic lymph nodes identified, you need to know whether there is any further distant metastasis, in which case you can do a PET CT later on.
Yes, sir.
In patients where you have about a 7 millimeter, 8 millimeter ilia group of lymph nodes, which you are not sure whether it's a reactive or a metastatic node, then you will do a PET CT to see if it is reactive or a metastatic. In patients post-treatment, after you treat the primary, to see if there is any residual disease or if there is a recurrence after you do the iliac dissection, then you will do a PET CT as a follow-up.
Yes, sir.
Or patients in whom there is an unknown primary. The patient has got inguinal lymph nodes. You do not know whether it is not applicable in this particular individual because this patient has got overt malignancy. In patients where there may be some inguinal lymph nodes, you do not know where the source of primary is from. Then you will do a PET CT. Otherwise, the answer
Yes, sir.
for that, what is the role of PET CT is, any patient who needs who needs a CT of the abdomen, you can always do a whole body PET CT, but that will not give you any additional information. That is the first answer that you'll have to give. But
Yes, sir.
if in case there are some equivocal findings in the regular CT, then you can probably go for a PET CT. Okay?
Yes, sir.
Equivocal findings that you get in a CT or in your MRI or in patients with the pelvic lymph nodes where there is a possibility that there may be further spread elsewhere. In this case, you can go for a PET CT. You understand?
Understood, sir.
Dr. Srinivasan, anything more you would like to add? Because it was a uh, very relevant practical question. Anything else, Dr. P.V. Srinivasan, you would like to add?
Sir, one more doubt is, if the
Yeah.
patient is having groin nodes
Yeah.
and we are unable to decide whether it is reactive nodes or metastatic nodes,
Okay.
in that case, if we take CT, PET-CT, if
Okay.
it is due to reactive nodes, it will also take up the FDG PET. So, is there any role of giving antibiotics for some period and then repeating the PET-CT?
No. PET-CT, if you want to do, you will do a PET-CT not to see whether the node is a reactive node or a metastatic node. You will not do, because always you should do a PET-CT after covering the patient with 2 weeks of antibiotics. Without 2 weeks of antibiotics, if you do a PET-CT, the report will always be fallacious. If you get a Hounsfield, if you get an SU value of 10 or 11 or 12, the diagnosis becomes easier for you. But many times what you do is you get a report of 5, 5.56, neither this side nor that side, neither below 4 nor above 8. You get in the equivocal range where you are still not sure whether that particular higher SU value is because of infection or an inflammation or because of malignancy. The whole PET-CT becomes a futile exercise. So that is the reason why nobody does PET-CT these days as an initial evaluation for CA penis. Only if the CT abdomen is equivocal, when it is not contributory, or if there is a 4 centimeter pelvic lymph node which is identified in your CT. Then you would like to see whether there are any further paraiotic nodes, whether there are any metastatic group of nodes, or whether there are any distant spread. Then you will go for a PET-CT in those instances. Otherwise, PET-CT as an initial modality of treatment, of evaluation, is not useful, not relevant at all. So normally in the exam when they ask you, you will not say PET-CT. But
Yes,
if you
sir.
say PET-CT, the next thing that they will ask you is it FDG PET or anything else? FDG PET has got its own problems also. There are frequent false positives that you get with your FDG PET. And that is the reason why people have started talking about the PSMA PET for such individuals with CAPNS. The PSMA PET. PSMA is the glycoprotein which is expressed not only in prostate cancer but also in non-prostatic solid tumors, especially the squamous cell carcinomas. It is very useful in patients with head and neck malignancies, cervical malignancy, cervix, and CA penis, which are predominantly squamous cell carcinomas, where there is an overexpression of PSMA, and that will get rid of all these fallacious reportings. False positivity will not be there in that. Okay, lesion which is very small with less glycolytic activity, all that will get missed out here if it is a if it's a well differentiated lesion with less glycolytic activity, with less glucose metabolism, FDG may show false negativity also. And these are the instances where people have started moving more towards the PSMA PET. Still, it is experimental, but if at all PET-CT you want to do, it will be only FDG PET as on date. Okay,
Okay, sir. Thank you.
Srinivas. Has it answered your query?
Yes, sir. Completed, sir.
Yes, and somebody else, Jaiswal, has asked, sir, what to answer if asked size cutoff for metastatic lymph node on CT? It's very, very clear. An ultrasound will pick up a lymph node which is 2 centimeters and above. A plain CT will pick up, plain CT of the abdomen will pick up a node which is 2 centimeters and above. A contrast CT will pick up a lesion which is a lymph node which is 1 centimeter and above. A contrast CT where there is oral and IV contrast given, it will pick up a lymph node which is 0.5 centimeters and above. MRI will pick up again a lesion which is 0.5 centimeters and above. So if you ask for a CT abdomen, it has to be oral and IV contrast, where the nodes which are 0.5 to 1 centimeter nodes, which are otherwise missed out in your regular IV contrast, they will all get picked up in your oral and IV contrast. Okay, CT abdomen.
Yes, sir.
Okay. So you have done a
Yes, sir.
partial amputation of penis. So what is the biopsy report now? Biopsy report is
Sir,
something.
biopsy report came as a tumor site glans penis, tumor site 16 to 5 into 2.5 centimeter.
No, your voice
Histological
is
type
breaking.
squamous cell carcinoma, moderately
Okay.
differentiated. Hello, sir. I'm audible, sir.
Yeah.
Sir, partial penectomy HP came as 6 into 5 into 2.5 centimeters, squamous cell carcinoma, moderately differentiated, T3 tumor invading corpus spongiosum, cavernosa, and urethra. Margins resected are free from tumor infiltration. Perivascular perilymphatic invasion is not evident. Perineural invasion is present. So T3, sir, PT3, sir.
See, when it is a T2 and above, there's a lymphovascular invasion. Perineural invasion does not really have a great role to play. This perineural invasion and the lymphovascular invasion will have a significant role to play only in instances where it is you want to differentiate between T1A and T1B.
Yes, sir.
Only in those individuals you'll be able. If it's invading the subepithelial connective tissue and not gone into the spongiosum, there you want to distinguish between A and B of T1, then that lymphovascular invasion will have a role to play. Otherwise, by and large, if it is already a T3 lesion now, with the lymphovascular, without lymphovascular, treatment is the same. Isn't it?
Yes, sir. Yes, sir.
Okay. So now you have a patient with a T3 lesion, clinically N0.
N0.
Okay. You have still not done a inguinal dissection or iliac dissection. Okay.
Yes, sir.
So what do you want to do now?
Sir, after 2 to 3 weeks, we need to plan for bilateral superficial inguinal node dissection, sir.
Srinivasan sir, would you like to add anything more to it, sir? Up to the evaluation and initial management. We'll move on to the lymph node management now. Dr. PVS, anything
Sir,
you would
I
like
have
to add?
one doubt, sir. Yes, sir, I have one doubt, sir.
Yes.
During the initial surgery, either it's a partial or a total, whatever this thing,
Okay.
what is the margin? Actually, in this type of tumors, there will be some induration, clinically some induration around the tumor.
Okay.
So how will you assess whether it is a real infiltration or it's a tissue reaction to the tumor, and then assess the margin?
Induration, if you see, it is malignant unless proved otherwise. You cannot you cannot take the induration alone and send it for biopsy to see whether it is an inflammatory induration or a malignant induration. If you feel an induration, you have to give another 0.5 centimeters clearance further, in which case, if this is an inflammatory induration, you would have actually ended up giving a 1 centimeter clearance. It is always better to err on the normal side rather than erring on the inflammatory side. Thinking that it is inflammatory, if you leave behind some residual tumor, then you have to go ahead and do a completion pinectomy on a later date, which is not warranted here. So if you palpate some induration, it is always prudent to consider that induration as a malignant infiltration and go further 0.5 centimeters proximal and see whether it can still give an adequate stump. If you're in doubt in giving an adequate stump, it is always better to go for a total amputation in such a setting.
Okay, sir. Okay, fine.